Our next speaker today is Professor Zoe Wainer, Deputy Secretary for Public Health in the Victorian Government Department of Health. Zoe has previously worked as Director of Clinical Governance at Bupa Australia and New Zealand, as Chair of the Board of Dental Health Services Victoria, and as Director on the Board of the Victorian Responsible Gambling Foundation. She also has a clinical background in cardiothoracic surgery and thoracic surgical oncology. Zoe will speak to us today about value-based healthcare. Welcome, Zoe.
Good afternoon, everyone. It's an absolute honour to be here. Thank you so much for the invitation and the opportunity to present to you all. I wish to start off by acknowledging the traditional custodians of the land on which we are meeting today, the Ngunnawal people, and pay my respects to elders past, present and emerging. I would also like to acknowledge any First Nations people who are in the audience. It's a great pleasure for me to have an opportunity to share something I'm very passionate about, which is value-based healthcare, and it's probably value with a slightly different meaning. And thank you, Angus, for providing some fantastic examples for what I'm about to speak about. So before I go too much further, I would like to just thank some of my colleagues who I think are online as well today, who have contributed to a lot of this work. I think the value-based healthcare community is quite an amazing international community, and we really support each other and work closely together. And I know two of my colleagues, Sian and Russell, are in the audience as well, and Richard's always been such a supporter and champion as well. But also to thank my team in the department, Maria Bubnik and Holly Piontek Walker, Kate Gibson, as well as Steve Gilbert from Gilvan, and Sue McKee, the CEO of Dental Health Services, and I'll give you some examples of their fantastic work. So I thought I'd start by looking at our healthcare system about where we are now and what is the case for change. We have, as we've heard, a growing pressure from people suffering from chronic disease. We have an ageing population. We have rising inequalities, which we've seen COVID lay bare. We have increasing costs of care, and as Michael made the observation, technology seems to only increase those costs. And we have ongoing impacts of climate change, of which, potentially we're seeing some of that with COVID, Japanese encephalitis, and other diseases that we are seeing impact our population's health and well-being. And we're trying to manage these and other impacts using a model that's no longer fit for purpose in our healthcare. It doesn't deliver the care and health outcomes that we, as clinicians and as patients, want to receive. We have a system that is focused on treating and paying, as Michael talked about, for episodic illness rather than keeping people well in the community. We have inappropriate incentives that prioritise the reward for activity, and whilst that's been a very powerful way of funding our system, we now realise that it's actually potentially driving low-value care and doing more rather than delivering better outcomes. We have a system that's focused on activity outputs or service performance rather than outcomes and experiences that matter to individuals, to populations and to communities. And as a result, the nature of patient journeys is unnecessarily complex, utilising a highly fragmented care delivery system that's organised around clinical disciplines, not the patient experience or the patient journey. I think we need to fundamentally start thinking differently about how we achieve the best health outcomes for our community. Central to that is understanding what health and care outcomes patients value most and prioritising that as a broader healthcare community. So this is touched on a little bit in Michael's presentation as well, but there isn't a correlation necessarily between a greater spend and better health outcomes. And there's no better country to illustrate this for us routinely is America. You can see them as a real outlier there. The only countries that are marginally on the right side of the line really are Sweden, Norway and Switzerland, where we're seeing potentially a greater correlation. Things are not going to improve unless we actually really start to challenge this and factor in issues such as the ageing population, increasing chronic illness and increasing costs of care. But we have to do it with the right principles in place in the first instance so that we can shift the result in terms of the value we get from our health spend, getting the best health outcome from the dollar that we have. So why do we need change? Obviously there are a number of primary factors driving the need for truly transformational change in our health system. as we've already touched on several times and is clearly a focus, is the rise and high cost of care. Unwarranted variation and errors in care that drive low value delivery of care, fragmented and disjointed care delivery, changing expectations of patients, of clinicians and staff. You know, our patients want a better health outcome. We have staff who are burnt out, who feel like they're not actually able to make a difference. And we have inappropriate incentives in our system driving volume and leading to cost shifting, and incremental solutions are just not going to work. We need genuine transformation across the system. So, you can tell me whether this is right or wrong. This is certainly some work that was done through Dental Health Services Victoria, which is the statewide public oral health sector in Victoria, and they wanted to understand what's a driver for change for patients, for consumers, citizens, clients, whichever language feels most appropriate. So as clinicians, you know, we sometimes assume that we have a shared understanding with patients about the outcomes that they value. While some of those on the list are obvious, none of them should be surprising. That patients want to enjoy life without poor health, to know how to prevent poor health so that they can be active participants in their wellbeing, to be supported to make good health choices, to have an active role in decision making about their own health, to be listened to and have their views and their time respected, not have waiting rooms, for example, to have help from providers in the coordination of their care. Although if we had a truly high-functioning system, they wouldn't need coordination because the system would be organised around them. And to have providers come to them, rather than always this sense of travel, and gosh, haven't we seen rapid transformation of that during COVID-19, and how do we keep the best elements of that? So what about our clinicians? What's their experience of the system? So these are some of the things that they told us. Clinicians actually, they really genuinely want to improve health outcomes. They want to know how they're contributing to somebody's health and well-being. Isn't that why many of us, or all of us, chose to be in the profession? People repeatedly return for the same health problems, and that gives the clinician the sense that they're not actually getting there. We use the same approaches over and over, and we have a system that doesn't support clinicians to really deliver those health outcomes. They see and hear the wait lists growing, and they know the consequences of that is poorer health outcomes and a frustration of being in a system where they can't actually influence that. That's certainly one of the reasons I chose to step out of the clinical role and into a system role. So what does the health system want to change, or those of us in policy roles? I mentioned earlier about rising consumer expectations and what some of those are, and they're not unreasonable expectations, and the system wants to be able to respond to those in a positive way. Again, we hear about the increasing costs across the board. Population growth and ageing, and how do we support our communities to be healthy? Yes, we have a long lifespan, but what's our health span like? Because my understanding is, in fact, Australia doesn't always perform as well as it could or should when it comes to the number of years spent healthy. We have the rapidly evolving technologies and the new medical knowledge that exists, but so often we can't access it, as we've heard, or optimise the use of it to really improve those health outcomes. We have uneven quality and significant variation in care and health outcomes. And one really powerful example of that is just looking at the difference between men and women with health outcomes, both in cancer as well as in cardiac disease and mental health. There are disparities between men and women, for both men and for women, where they have poorer outcomes. And we do have an increasing burden of chronic disease, where we need to think about a shift from cure to care, and again focusing on the outcomes that patients, that our communities want. So what is value-based healthcare? It's a bit of the new black. I've heard the language lots, and I hear a lot of people talk about it, and it has many different meanings. So I thought I'd just start with a bit about the definition of, when I use the term value, what I'm referring to. And it references work that was done by Elizabeth Teisberg and Professor Michael Porter at Harvard Business School in early 2000s, and then built on in this framework that you see here around 6 principles. And I won't go into detail of all the principles there. But at the heart of it, it's about understanding the outcomes that matter to patients and improving those outcomes. It's about using what we know works in quality and safety in terms of improving and continuous improvement of care. But it also means bringing some business principles in, such as customer centricity. You know, I think the waiting room is such a good example, and I often think about if you took the way, in fact, there's a fantastic video on YouTube about what if restaurants operated the way that the healthcare system operates. It's worth Googling because it's really quite interesting and challenging, and needless to say, you get interrupted multiple times to ask about your allergies during your meal, which I'm sure those of us who've been patients know what that's like. But it's also about how do we use theories like competition theory so that we think about and deliberately design our system so that the incentives of all the stakeholders are aligned to a good health outcome for the patient. And whilst that's the desire of the stakeholders now, we're not always actually incentivising appropriately in that direction or aligning that. We actually have a system where we have incentives diametrically opposed at times, and that also means that stakeholders inherently don't trust each other in that system. So how do we bring these principles together? And you can see there are 6 principles in a framework there. Lots of them aren't new to healthcare or to business. But they are new in how they're bringing them together in that framework. So what does value-based healthcare offer? So it offers the opportunity to shift the health system from one that's driven by volume, driven by activity, as we've heard, to one that's driven by value, focusing on the aspirational goals of the Institute of Health Improvement, triple aim, around improving the health care, improving health outcomes and optimising the investment, as well as recognising the really important 4th principle of provider and clinician satisfaction. The concept of value in healthcare has been around for a long time, and as I said, it has many different definitions, and it is preceded by various movements such as evidence-based decision-making, quality improvement, and of course performance management. A value-based approach builds on those movements and through meaningful engagement with people and populations places an emphasis on the outcomes that matter to patients and importantly equity in those outcomes as well. Value in the simple equation that we see here brings together that business thinking I referred to and the healthcare expertise around quality and safety. And by broadening the scope of costs to be not just the cost of delivering care, and importantly, that isn't the price, that isn't the funding, that's literally what does it cost the system to deliver that health outcome. We can actually broaden that, and I acknowledge the work of Anna-Greta Hunter and Angie Bone in my team, who's been doing work around this as well, about thinking about the environmental, the social, and the financial costs of delivering those outcomes as well. So I think it's really important that value in this setting, and I know this audience understands this very deeply, is not about cost saving. It's about the wisest investment for the best health outcome that we can achieve, and that health outcome, importantly, being the one that matters to patients. So why is measuring outcomes important? Measuring how well the patient gets as a result of their care rather than the process conformance is really vital to understanding what led to that desired outcome. In fact, Stefan Larsen, who is the Global Partner for Health at BCG, made an observation that in healthcare we measure process. We're wedded to measuring process. And in fact, all that does is stifle innovation. If we focus on the good health outcome and we encourage clinicians and patients to work together to work out what different processes might arrive at that we actually can get much better health outcomes as a consequence. It allows and fosters the innovation. It's necessary to collect outcomes that matter to each stakeholder as well, and that goes back to the incentivisation element and using some of the elements of competition theory. The Martini Clinic here is a really famous example of this. They implemented the 6 principles of value-based healthcare and they are a prostate cancer surgery centre in Germany, and they measure the outcomes that matter to men. Now, I think it's important to recognise that these are actually only showing you the negative outcomes. Part of the work of value-based healthcare is to actually say, what are the positive health outcomes and how do we start to measure that? Again, healthcare is very focused on measuring the absence of negative outcomes. But I don't know anyone who goes into surgery thinking, gee, I hope I don't go to ICU, I hope I don't get readmitted. You go in with a vision of the positive health outcome you want. But here we're only mentioning the negative ones, and we can talk about the positive a bit later. And they compared population-level data looking at 1 year incontinence and 1 year severe erectile dysfunction after prostate cancer surgery. And you can see how much better the Martini Clinic is in those results. And this does a few things. Firstly, I know that, talking about competition theory, I know Australian men who know about this data, who go to the Martini Clinic for their care because they're aware of how good those health outcomes are. Imagine if we had that across healthcare more broadly in Australia. And the other thing it does is it drives other healthcare providers to want to be aspirational and understand why the Martini Clinic is getting such good outcomes. It attracts the best clinicians, but it also means it went from a mid-sized cancer centre to one of the largest in the world in just under a decade, because it's really competing on outcomes that matter to the patients. I think in terms of thinking about what outcomes can be measured, and this is a really important element because, as I said, we're not routinely very good at measuring the outcomes that matter to patients. There are three key categories that are being worked up by the University of Texas Dell Medical School with Professor Elizabeth Teisberg, who are grappling with how do we actually measure what matters to patients and actually take the patient lens, not just the disease lens. And so they talk about capability, and this is over the full cycle of care. And that's the ability for patients to be able to do what matters most to them. And that's about better functional outcomes, the ability to do things. And sometimes that means not being disease or condition free, but having it managed in a way that allows them to have as functional and productive life as possible. It's about comfort, less burden of disease, less physical suffering and less emotional angst. And it's about calm. Can life go on during treatment of disease? Less burden of the treatment on the person, the patient, their community and their family. Less time, less hassle. How do we support that? There's a really powerful illustration for me around remembering the outcomes that matter to patients in work that Dental Health Services Victoria did, where they set up a value-based healthcare team and they had one of the patients come in and she had one not many teeth on her lower jaw, and one was cracked and it wasn't functioning, it was giving her pain, and they asked her, what was the problem, and they actually asked things like, can you eat? Can you drink? Does it stop you talking properly or feeling socially confident? These are things we've never really thought about in oral healthcare before. We think about how many teeth do you have and how many fillings do you have, but not the functional elements. Anyway, they got very busy making her a lower denture until someone said, hang on guys, we're the value-based healthcare team. Do we actually know what this patient wants? And they went back and said to her, what is the outcome you want? And she said, I just need that tooth capped because I can eat, I can drink, I can smile, I can talk. So we were about to completely fail the value equation. We were about to undertake an expensive procedure to provide her with something that wouldn't give her the health outcome she wanted, and she would have left that consultation with the problem that she still had. So I think this is another really powerful example and case study from the Netherlands. Diabeta is a paediatric endocrinologist who tells a lovely story about wanting to be able to create team-based environments, to bring his team around a table. So he went to the hospital that he was working in and said, could I please buy a round table, or could they buy a round table? And they said, no, anyone who's worked in a hospital understands this conversation. No, we can't do that. And he said, well, what if I buy the table? And they said, no, we can't do that either because then we've got to insure it and it's an asset. And all the barriers to trying to create team-based care, which are, felt truly obviously bureaucratic in that sense. And so he said, all right, I'll go and set up my own practice. So he and a colleague went and set up Diabeta, and they built it on the principles of value-based healthcare. Deeply embedded those principles of patient centricity and involving the family, because obviously it was paediatric care as well. And whilst this isn't necessarily an outcome per se, a positive health outcome, this is the HbA1c, so a measure of the control of the blood glucose of these children, and you can see how much better Diabeta is at in comparison to other providers. Now, what this did was in the Netherlands, basically it's predominantly private health insurance-based funding mechanism, and the insurer looked at this data and they said, well, hang on a second, we can actually model how much healthier these kids are going to be in a decade. So we can actually estimate how much money we're going to save. So they actually went into a 10-year profit sharing agreement with Diabeta, as long as they maintained that differential in terms of their good health outcomes. And to me, that's such a beautiful example of where you're starting to align the incentives. The insurer or the payer, whether it's a government or a private insurer, is able to save money so that they can actually reinvest that money in better health outcomes. The clinician gets the satisfaction of seeing the really good health outcomes, as well as getting a profit share. And the patients have the much better health outcomes and long-term future health vision as well. So just a little bit on understanding cost in value-based healthcare. It does get confused with funding. It does get confused with price. When we talk about cost, we actually mean the cost of delivering the care. And why that's so powerful is this is actually about giving clinicians on the front line the tools to understand where they're investing their time as a cost. And some really elegant, again, case studies about when you can help clinicians understand that level of detail of the investment that they're making, that they change their models of care because they realise they're actually not driving the best health outcomes with the investment either of financial resources or time resources that they have available. And then we can think about the funding, and that's a different process again. But it's about giving our clinicians the tools. And I get very frustrated when I hear people say, oh, clinicians aren't interested in cost. They don't really engage with it. Well, sure, when we give them things like NWAS or WEAS from Victoria or various other kind of mechanisms that we've worked out for funding. But when you give them meaningful cost data, it actually changes how they deliver their care. So what does a system built on value-based healthcare look like in practice? It's about care that's designed with and around the person. At Dental Health Services, we did a really important piece of work. We learnt very quickly that we didn't understand co-design, and we went out and spoke to the vulnerable communities who were the priority populations. And we learnt things like, that we didn't know, assumptions we'd made. People without homes are incredibly busy. It's very hard to get the basic resources you need when you don't have a home. Dental Health Services was sitting there waiting for people to come to us because we thought that that's just how you do care. And we learnt, in fact, that's a fundamental barrier for some of our communities. So truly designing care with consumers or with patients. In this system, the right care is provided to the right person at the right time, in the right location, by the right clinician. Value is used to measure effective and efficient resource utilisation and investment and outcomes that matter most to patients. Continuous measurement is utilised to improve care and remove unwarranted variation. Prevention and early intervention are prioritised at an individual and a population level, and prevention is seen as part of a person's journey in their care and health and wellbeing. And care is integrated, coordinated, and based on risk assessments. A benefit of focusing on health outcomes for the patient, for people, for our community is seeking that we return to the goal of health as a fundamental function of the role of the health system, not just, as Michael articulated, responding reactively to illness, helping people live healthy, happy lives. But there are other benefits too. Aligning with purpose to help people with their health concerns can also be an antidote to clinician burnout. This is why clinicians got involved. Never before has this been more of an issue for our workforce at the moment. And because the person is genuinely at the centre of the system, and the system is designed and organised around the person with their outcomes understood and their care designed to meet those desires. And we did a really interesting piece of work in the Victorian government called COVID Positive Pathways, where we looked at how do we actually triage people appropriately who test positive with COVID, how do we try to keep them out of the hospital system wherever possible. And it's the first time, certainly in my experience in healthcare, where I have genuinely seen primary care, community care, tertiary care join up as a system around the individual and meet their needs, and mostly that meant being able to keep them in the home. Thank you so much for listening and for your time today. Really appreciate it. Sorry.